Hey y'all, it's Molly Dunham-Friel from Better Bellies by Molly. I am a Galley Health Ambassador, and I have the pleasure today of being here with Hannah Schoonover, who is going to introduce herself, and she works at Body Connect Health and Wellness DC.
Hi everyone, my name's Hannah Schoonover. My pronouns are they and them, and I am a pelvic floor physical therapist here in Washington, DC, specializing in pelvic floor dysfunction and working primarily within a gender expansive environment. So we see everyone outside of the, outside of and within the cisgender binary.
Wonderful. So before we get started, we wanted to know, how would you define or explain for our listeners what the pelvic floor is?
Well, I'm glad you asked because I brought a demo.
Yay!
All right, so this is your pelvis and that's your pelvic floor. So the pelvic floor is the series of muscles inside of the pelvis. They provide a supportive layer and they work in conjunction with the other core muscles, the respiratory diaphragm, the deep abdominals, the spinal stabilizers, to create this really stable base of support so that you can move and function and groove and do all your things. They do have a portion of function, obviously, that is sexual, that is defecation based, urination based, but they also are just what you use to go up a flight of stairs and to jump on a trampoline.
Got it. So does everyone have a pelvic floor?
Every single human with a pelvis has a pelvic floor.
Wonderful. So could you also, to clarify, give us a little bit more information about what pelvic floor therapy is, and then dysfunction, and then how that can also relate to IBD and GI distress?
Yeah, so before we talk about what the pelvic floor is, function, all that stuff, I want to do a quick like housekeeping. The way I refer to the pelvic floor and anatomy is based in currently accepted medical terminology. So I do use words like vagina, I do use words like penis. That is not how I talk to patients, however. So in a gender expansive environment, the patient tells me what their body parts are called, and we always use that to work with them. But in the interest of continuity, I'm going to be using medical terminology for today. So pelvic floor physical therapy is not just my favorite thing in the world, but a really interesting thing. Pelvic floor physical therapy is the treatment of the pelvic floor muscles. So the way my brain kind of works about what that is if you tripped off the curb on your way to work and you sprained your ankle, you'd go to physical therapy, right? You'd be like, okay, I'm in pain, I'm limping around, it's a very obvious injury, I'm gonna take care of this. The pelvic floor has similar things. You can absolutely hurt your pelvic floor. You can have muscles that aren't firing when you want them to fire. You can have tension, you can have pain, you can have tearing, you can have distension, you know, all of these things that can happen pretty much anywhere else in the body can also happen in the pelvis, except when they happen elsewhere in the body, like falling off a curb and spraining your ankle, you can say, oh, look, I sprained my ankle. I can see that and I can work with that. Pelvic floor is much more insidious. You don't really see these nice clear cut symptoms. It's not like, ooh, you know, I tripped and did something to my pelvic floor and here I am, and I'm going to have the exact same symptoms as you, Molly. We're going to have totally different symptoms based on what we did to our pelvic floor, how our pelvic floor responded to that. And in doing so, it is a much more complicated and interesting and varied part of our bodies.
Wonderful. And then how would you say pelvic floor therapy relates to IBD and IBS distress at a whole? Like, what are some common symptoms inside and outside of the bowel and the pelvic floor region? Could you tell us a little bit more about that, specifically for IBD?
Yeah, of course.
Bowel disease, Crohn's and colitis.
Yes. So the thing that my my lovely lab assistant today does not come with are the pelvic organs, which kind of rest right in here. So the pelvic floor not only provides a supportive layer for the core muscles to function and, you know, sexual function, bowel, bladder, all that. it literally forms, it creates a space for which our orifices exist. So our pelvic floors go around the urethra, they go around the anatomical vagina, they go around the rectum and the anus. And in doing so, if you have a disorder on, one piece of that, when I say disorder, any sort of dysfunction is maybe a better word. When you have dysfunction along any piece of that, any of those orifices can be disrupted. So, a person might have urinary dysfunction, they might have sexual dysfunction, etc. So when it comes to IBD, we're talking obviously more on the bowel spectrum. And if you have, let's say, for example, increased tension around the external anal sphincter, around the pelvic floor muscles, specifically the puborectalis, around the rectum, if that gets really, really, really tight, the ability to sense when it's time to go, the ability to fully void, the ability to void pain-free becomes a lot harder. So with IBD specifically, we'll see a lot of straining mechanics, a lot of like pushing, straining, frequent defecation, the frequency urgency piece of all of that is really intense.
Yeah, we know all about that.
Yeah, that's preaching to the converted, right? So the pelvic floor then has to kind of work with that. So, straining is a really great example. So IBD, one of the more common symptoms, diarrhea. With diarrhea, people often think of diarrhea as being easy to pass. It's loose, it kind of just falls out. That is not accurate. There is a looseness to the stool, yes, but your body is still going to clench around the lower rectum to make sure that you are not going to have an accident in public. You kegel really, really hard to make sure that you're safe, that you're culturally appropriate, all that stuff. So diarrhea is often very much correlated with rectal pain, rectal fissures, rectal bleeding, hemorrhoids, all of the hemorrhoids, all of them.
So would you say that the clenching that a lot of us, myself included, as an IBD patient, the clenching that we have to do for fear of accident, for preventing an accident, for making it to the toilet or anything in between, would you say that that clenching in itself could lead to some dysfunction in the pelvic floor?
Absolutely. You take a person, take your biceps. If you spent all day clenching your biceps and then you want to go and pick something up by extending your arm, it's not going to go. And it's just exactly the same in the pelvic floor, except the function there is something that no one wants to talk about. Who wants to go to their doctor and say, I'm having a really hard time clenching to hold stool back? That is a hard sentence to say. That is a hard thing to talk about. And so people suffer needlessly for a really long time before they realize, there are things that we can do. We can work with these muscles. It's just muscles, just like the biceps, just like the muscles in your ankle. We can rehab them.
I totally agree. So now we would like to know a little bit more about how do you help patients with these things now that we understand that pelvic floor dysfunction is common and very likely in the IBD community. What kind of typical treatments do you use? What does the typical appointment look like? And then I have some follow-up questions.
Well, any sort of pelvic floor physical therapy appointment, one can strike fear in the hearts of many. It can feel very off-putting to go to a physical therapist and receive any sort of like genital-based inspection or palpation. So when you come to our PT practice, it's not just hello, nice to meet you. It is a very slow, methodical, consensual experience. And a lot of it is based in orthopedic structuring. What is this person's posture like? How are they standing? How are they moving? Can they bend, twist, lift? Do they breathe properly? Can they contract any of their core muscles outside of the pelvic floor? And you get a nice kind of broad picture there. So often that's, 50% of an appointment is just, where are your hips? Where's your spine in space while you're doing these things? And then the latter half is kind of the pelvic exam. And that can look like a lot of different things for a lot of different people. So what we always tell people is, internal work is never mandatory. We never have to go into the any orifices, into any of the genitalia. It's ideal, sure. but we can work around in cases where people really, really don't tolerate that. But the internal exam is exactly what you would think of as an internal exam. We can do a vaginal or an anterior whole exam, or we can do a rectal or a posterior whole exam. And that involves one finger, lubricated, gloved. And just like we saw with the muscles inside the bowl of the pelvis, we go in and say, hey, how does that feel? How does that feel? Can you contract here? How does that feel? It's not a heavy palpation. It's not a super intense experience, hopefully. We try to keep everything on the side of, you know, not provoking pain, not provoking like a strong emotional response. We want things relaxed and, you know, kind of chill. So does that answer your question?
Yeah, no, that totally makes sense. And I really, you know, feel, and I hope other people listening feel a little bit better knowing now what they might expect. And so I think also the one finger versus two finger thing, is a one finger standard practice, or does it kind of depend based on which physical therapist we go to?
I would say one finger is standard practice. There are definitely patients in my career who have gone up a finger, and that is more based in, do I need the strength of a second finger? It's less to do with, can you tolerate girth? I mean, there is an element of dilation that sometimes does have to happen, and two fingers are more helpful. I have never done a two finger rectal palpation ever in my career. I don't think that's super necessary. So from like a pure like IBD perspective, someone who's coming in specifically with a bowel based disorder, it's going to be one finger always.
Great, awesome. So when you're treating IBD patients, is there a difference when you're treating different genders?
Yeah, always. So when it comes to treating different genders, there are a lot of considerations for every gender, right? Like there's an element of cultural competency when it comes to literally any gender in this world. And so let's take, for example, a more gender expansive look. So maybe looking at a transgender community. A lot of folks who are in the trans community, even if they have the anatomical vaginal structure, might not really be too keen on a vaginal exam, even if that information is really important. So a lot of the time, the anus and the rectum are a very inclusive way to get this roughly the same information. Obviously, you can't palpate the sphincters through the anatomical vagina, but a lot of the time that opens up a world where people don't have to experience really intense gender dysphoria in order to get, you know, care for their bowels, which, you know, in the grand scheme of things, I hope that bowel care is not too rough on gender. You know, I would hope that that is a little bit more easy to tolerate for folks who maybe are going through some gender dysphoria.
Got it. And we'll have some more questions about like the LGBTQIA plus community and inclusivity further on. But first, we're going to finish the IBD section, if that's okay. I have some more questions that are geared more towards inflammatory bowel disease. Are you familiar with what a J-pouch surgery is, where your rectum is actually removed and you have one created for you? We were wondering if there was a difference in therapy in terms of pelvic floor therapy, of course, if someone has a J-pouch or has had surgery, or if their disease is active versus inactive. Some of that might be a little obvious, but could you just explain for the group, in case there's folks who are wondering, should they wait until they're not in a flare, or how should they proceed? Because everyone is in a different state, of course.
Yeah, when it comes, like flaring is a really great place to start. With an active flare, one conversation is always a conversation about consent. I personally trend more towards not treating directly in a flare. That said, there is plenty of stuff that we can do in a flare to potentially calm a flare. It's just maybe not so direct. You know, I'm not going to be, you know, poking at any sort of like anal or rectal space if someone is actively in a flare. Like that's cruel and unusual. But we can do like abdominal work and maybe some stretching and maybe some breathing, and then all that can make things feel better. J-pouch specifically, I can't say I've done an internal rectal exam on that exact post-op situation.
Okay.
But the pelvic floor muscles don't change. So it depends a lot on how the patient is presenting, what their exact surgery looks like. But you still need, a functioning internal and external anal sphincter. You still need a functioning puborectalis. You still need a functioning, levator ani, which includes the puborectalis. All those things still have to function for people to not just have healthy bowels, but to live, to have a functioning life. So it does change, but one, having never personally experienced it, I can't give you exact information, but I would work very closely with that patient and their particular body.
What would you say, or what advice would you have for our patients who have perianal disease, including fistulas or even abscesses and fistulas that are chronic, meaning like there's not really an end in sight for their fistulas? In terms of pelvic floor therapy for them, would you still encourage them to seek treatment? Would the treatment be different? What might that look like?
Yeah, absolutely. Pelvic floor therapy is very helpful. Again, so much of physical therapy isn't necessarily, how we think of curative. I'm not going to magically fix a fistula, right? That would be amazing.
Yes. Very wealthy. We would personally
Be incredible.
be wealthy. One day.
But again, we can support the muscles around the fistula. We can make sure that why is the fistula continually occurring? Is this person really straining? Are we rupturing previously healed tissue? Can we do anything internally, or potentially more importantly, can we do anything externally? Does this person know how to bear down? Does this person know how to breathe? Can this person actually get that full pump mechanism of the respiratory diaphragm and the pelvic floor to actually move in time when they need it to? So that was that's more what I find when it comes to that particular diagnosis, like the chronic fistulas, that sort of thing, is, we're not poking fistulas, we're supporting the space where the fistula is occurring.
Right, which would be very important. I mean, I think it sounds like it's important for all bodies, really. But I have another question directly related to IBD is, are people with IBD at a greater risk of pelvic floor issues when going through childbirth in the postpartum period? Do you know if there's any correlations between IBD making it more challenging or worse, or is there not really a lot of data? Do you know anything about that?
I have read no formal data on that exact scenario, but I can say anecdotally, they're absolutely correlated. They're absolutely related. Again, the pelvic floor goes around the urethra, anatomical vagina, and the rectum. So if you're pushing something out of the vagina, the same muscles that surround the rectum are going to be similarly disrupted, deviated, distended, just like anything else would be. So folks who are already at a significant disadvantage when it comes to positioning and functioning of that region, sure, they might have additional disadvantage. That would be very logical. Of course, you always have, people who are amazing, who just, have IBD and have like the world's most perfect birth, which is like, cool. I would say that's not the norm.
Are there any typical things in IBD patients who go through childbirth? Are there typical things that you see as maybe things that we could bring up to our medical providers to be like, I'm having this, or I'm experiencing this, or I want to look out for this? Because a lot of us as patients have to be our own advocates and we don't know what to ask for. Is there anything specific that we should be asking about or thinking about ahead of time?
Absolutely. Yeah, 100%. That's such a great topic to bring up. When it comes to like self-advocacy for someone who has IBD, especially in the postpartum phase, what is different? You all know so much about your individual functioning. Like when we do intake questionnaires for patients who have IBD, the norms that we are taught in school don't always apply. Maybe, patient X's norm is to go to the bathroom and have a full bowel movement 12 times a day. That's not abnormal in an IBD community. Without IBD, okay, something's really funky and maybe we should get this person diagnosed. So say that person then has a baby and say now they're going 4 times a day. Any doctor is going to say, oh, you're going 4 times a day? Wow, you're really regular. But actually that might feel a lot like constipation. That might feel a lot like irregularity. That might be wrong for that particular person. So know your norms and know that obviously there are factors that happen with pregnancy and birth, hormonal changes, lifestyle changes, postural changes, sleep deprivation based changes, but roughly your norms should still be your norms. So that would be my big cue for folks. Yeah, that'd be the big one.
That's awesome. Thank you so much for that. So what are the most common ways to treat pelvic pain? We researched online and found that Body Connect Health and Wellness shares 4 different ways. What are the specific ways that you treat? We have myofascial release, pelvic health physical therapy, visceral manipulation, and craniosacral therapy as like sort of the 4 main ones. But could you elaborate on that for the audience?
Yeah, so those are 4 different schools of thought when it comes to treatment. The pelvic floor portion is obviously for the pelvic floor, but myofascial release is the treatment of fascia, and that can be anywhere in the body. You can get myofascial release on your shoulder, you can get that in your pelvic floor, and the fascia is the connective tissue in your body, and it connects all of your bits, all of your pieces. So if it's really tight, you get poor muscle functioning, you get postural changes, all those things that can again impact the pelvic floor. And myofascial release looks a lot like it has a lot visually in common with massage, so it's a very hands-on palpation, warmth, healing based kind of vibe to it. Visceral manipulation is treatment of the organs. So organs need love too. You have inherent rhythms and timings that happen in your body, and certain things have to happen at a certain time in various phases of breath or in various phases of cerebral spinal fluid going up and down your columns, and the organs respond to that. So if the organs fall out of rhythm, if they fall out of sync, if they're not moving, grooving, if they've been pushed to the side, if they're really inflamed, they're not going to function all that well. And I mean, the pelvic organs are, some pretty big organs. They're pretty important. So visceral manipulation is how we give the organs a little bit of love. And that looks, it is a very, very gentle looking technique. It's incredibly light touch. It doesn't look like too much a lot of the time. There's a lot of kind of fun positions your body gets to be put in, but watching it looks, I don't really have a good analogy for that. It's kind of its own beast.
Okay.
And craniosacral therapy, we also do something called core synchronism. They share a lot of overlap, is the treatment of the cerebral spinal fluid and the ventricular filling and releasing that happens within the brain and the cranium. And all of those rhythms, similarly to visceral, they have to have certain timings and certain functioning in order to work. And it's a full body treatment. Is a full body issue. And that looks a lot more, it looks very similar to the visceral. It's a very, very, very light touch. It's a lot of like, everyone get real quiet. It's not really a chatting kind of activity. But all 3 of the ones we just mentioned, all are basically geared towards getting the body back into a sense of homeostasis, whatever that looks like for that person. And again, mine might not look like yours, but it's all about just promoting a nice balance to everything. And then the pelvic floor work on top of that is the actual direct palpation of the pelvic floor, usually utilizing a craniosacral, an MFR, and potentially a visceral, depending on your palpation location.
Okay, great. So before we jump into the next topic, do you have any home exercises that folks with IBD or even other types of gut dysfunction or gut issues, any home exercises that we could do? Or what do you think about that? It's kind of hard to ask on video, right?
It's not so much that it's hard to ask as it is every person's different. So there's not really one like, aha, if only every person with IBD did this one thing. That'd be, again, super cool.
Easier too.
Seriously, oh, it'd be amazing. So again, a lot of the time with IBD, you do see more of a hypertonicity in the pelvic floor, like a tightness, a clenching. And so we do often prescribe things like choose happy baby, like because that causes pelvic floor opening and relaxation. But you can also similarly have a person with IBD who has muscle atrophy and fecal incontinence and urinary incontinence, and they probably wouldn't want to distend those muscles as much as someone who is hypertonic. So it's like yes and no to that question.
Okay, no worries. So now we're going to jump into the next topic, which is about the LGBTQIA plus community and inclusivity within the pelvic floor therapy profession. And so Body Connect Health and Wellness focuses on gender inclusive pelvic health, which is awesome. And Hannah, you have a passion for treating those who identify outside of cisgender. Is that right?
Correct.
So could you share with us how you and your practice help those patients and all patients feel safe, comfortable, and heard?
Mm-hmm. Yeah, so this is our big passion, particularly with me, but also the practice. And a lot of it was born from the stats. So there's a 2015 survey done that showed that a third of the trans patients who were surveyed experienced medical bias at some point, and that could be verbal harassment, neglect, whatever horrible thing you want to throw in there.
Right.
And 23% actually just flat out avoided medical care. There's nope, not going to do it. So with those numbers, one, the bar is pretty low.
Yeah.
We were like, cool, there's an opportunity here to be excellent easily. And so we changed a lot of things about our practice. Namely, we changed our intake forms. So we ask about pronouns, we ask about anatomical language. Again, do you use anatomical language consistent with your sex assigned at birth? Do you have words that I should use instead? We do not dead name our patients, which is we don't use the names that they were assigned at birth if they have had a name change, legal or otherwise. So there's a lot of just before they even walk in the door, they know we see you for who you are, we got you, and you're safe.
Right.
And then once they're here, kind of the big topic of the day, or one of them, is bathrooms. We have gender neutral bathrooms, so it's go do your thing. And our treatment rooms are also geared towards promoting safety. So a big thing is oftentimes for an intake, I'll have a patient sit up on my treatment table and I'll be down on my stool. So I'm always below my patient looking up. So there's always a sense of, hey, there is a power dynamic here that I'm actively not going to be engaging in. You are in control. You have all of the control in the situation. And then when it comes, say, down to a pelvic exam, they're always faced away from the door. So if someone were to inexplicably burst in through the door, no one's going to see anything. They are fully covered the entire time. And again, the concept of consent is just over and over and over and over. Like, my goal in life is to have patients complain about how much consent work we keep doing. They're like, Hannah, I've already consented. I'm like, you're going to consent again. We're going to keep doing it.
Right. That's definitely
that's the dream.
awesome. Well, thank you for that.
And I would say that those, yeah.
So this is a big one, and it's definitely geared towards, how do we make what you do available to everyone around the world and the country, right? So what tips do you have for other healthcare practices and providers? Because some people listening might also be providers. And how can we help our providers be better to support the trans and non-binary community?
Yeah, a lot of that comes down to cultural competence. You can't start practicing, these techniques working with this population until you know the terminology, you know the words. Maybe you know some actual trans or gender expansive people. That's a super helpful thing. And so when it comes to getting other providers kind of on the same page, we do a lot of work to, like, here's what new patient forms can look like. Here's what a pronoun is. Here's the language that is going to be really appropriate. And a lot of that comes in the form of, hey, Dr. Q, I'm going to send you this patient. This person is gender expansive, and they're going to need you at your best. And here are the words that they use. So a lot of it is me prepping that particular doctor for that particular case. But I often find that you do that a couple of times, And people start to realize, oh, we should really be doing a lot of this ourselves. We should be taking this information in and adjusting stuff on our end, not having Hannah make kind of an overt, show of this particular person. It should just be standard. And it's happening. It's happening in real time. And that's really great to see.
That's awesome. Did you want to mention any of your upcoming trainings?
Trainings?
For like healthcare providers? You have trainings where you kind of educate other providers so that they can include what you include in their practice?
I don't believe I have any upcoming trainings. COVID, I think, kind of just decimated my schedule. But before quarantine, we did a training over at Whitman Walker for the doctors and providers over there for gender inclusive. And in 3 weeks, I think, roughly, give or take, I'm going to be involved in an ISWISH panel on gender inclusivity, and that will be with other healthcare providers for healthcare providers. And that'll be a Zoom conference for ISWISH members only.
But that's awesome. That's how it gets started. Thank you for doing that. I know I'm thankful that you're in this space and making these big strides. Now we have some questions from our live audience. So the first one is, what resources do or should GI gastroenterologists should they have to help transgender clients for emotional and medical support? Do you have any ideas of what GIs should maybe have in their office?
That is such a good question.
That was from
yes
one of our
no. Oh, it's a solid like home run right out the gate. I can't speak to specific resources, especially in that particular intersection. Like, there's no amazing book or amazing blog that is gender expansive and IBD, kind of together. There are several books that I really do enjoy from a sexual health perspective that, again, because sexual health goes into bowel function, there is crossover. And I obviously, now that you're asking me for resources, I'm like, I've never read a single book in my life.
It's okay.
But I would be happy to provide a list at the end that we could post for folks. That would be very easy.
That would be great, because I think a lot of people, we all have a lot of questions, and we're still sometimes learning our own bodies. I mean, I feel like I'm sometimes still learning my body. But that was a great question. Another question from another Galley ambassador is it more common for those with IBD who've had surgery to need pelvic floor therapy, potentially scar tissue, displaced organs, things like that? A lot of people have their colon removed. A lot of people have more than one organ removed. Does that mean there's maybe a greater need for a pelvic floor therapy?
Yeah. I don't know if the answer to that question is as black and white as the question. Obviously, yes, in any instance of surgery, the need goes up. That said, we've seen plenty of folks who've never had surgery who need a lot of pelvic floor therapy. So I would say generally the trend is an absolute yes, but it's not applicable to everybody.
Okay, that makes sense. What kind of manual PT treatments can be helpful for IBD patients who've had, oh, that's kind of the same, who have the scar tissue? I'll just skip over that one. But another one is, how can we educate GIs on how to treat the transgender IBD patients who might be on hormone therapy? And does the hormone therapy impact the IBD meds that we're on, like immunosuppressing drugs, prednisone, and things like that? Is there any special care that you take in your practice, or any advice you have for folks who might be listening in, who feel that that's something that applies to them, where they're maybe going through a transition and they're on all these hormones, but then they have to take all these other immune suppressing or steroidal drugs?
So I can't speak to medication, is technically outside my scope of practice. That said, anecdotally, totally fine. the few folks that I've seen who are at this particular intersection, and it is a niche intersection for sure.
Oh, for sure.
It's not the most common patient population, but no, taking hormones, going through a hormonal transition and or surgical transition, no, it would not impact any healing times. It would not impact surgical outcomes. Again, I can't speak to the medication component, but I've never had a person have an interaction there. It may exist, but I don't know.
We have another question. Are there things that we can do, and I'm not sure if you can answer it, but we'll just ask it anyway. Are there things we can do to prevent having pelvic pain?
Absolutely. That's a great question. What I lovingly tell every patient who comes in here, you got to learn to breathe every single time. If your respiratory diaphragm is not functioning optimally, it does not matter if you've had surgery. It does not matter if you have all of the pelvic floor disorders. Something is going to go wrong at some point. So if folks know, maybe they have a family history, you know, maybe they're in the early stages of being diagnosed with IBD, YouTube videos, work with a PT, work with a breathing specialist, you know, whoever you have at your disposal, and really make sure that that diaphragm can fully lower and fully raise back up. Because that is how we massage with our breath, the abdominal organs, the pelvic floor, all of the really important stuff that's kind of in our middles is entirely dependent on breathing.
Since we're all in quarantine right now, is there something that we can do at home to figure out if we are actually breathing properly and actually using our diaphragm correctly? Like, should we put our hands somewhere? Is there something that we should practice?
Yeah.
Breathing isn't as easy as it sounds sometimes.
It's not. No, breathing is one of those where, you know, you've been doing it your whole life and now someone is telling you, ooh, that might be doing it wrong. Your brain doesn't know what to do with that information. It can feel very off-putting, very frustrating. So two things that I always start with is one, how much is your chest moving? So if you are kind of breathing, getting a lot of throat activity, getting a lot of chest activity, your diaphragm's probably not doing what it should be doing. So starting there, if you can put your hands on your chest, how much are your hands moving? And also, like right now we're on a Zoom Facebook situation. I can see myself. I can see how much my throat contracts when I do a big chest breathe. Use a mirror, use a video. When you're conversing with your friends, be like, yo, look right here for me and tell me if I'm doing some funky stuff. They're gonna know pretty easily. The second is the ribs. People often think of abdominal breathing or belly breathing as this very pregnant breath. You fill forward. It's actually a very expansive breath. You actually like go out to the sides as well. So if you can kind of, you know, take a trip back to the mid 1990s with model, you know, posing, and put your hands really, really, really high in your rib cage. When you breathe in, the ribs should come apart, like kind of like wings coming away from you. When you breathe back out, they should come back in. So if you can recognize rib mobility or lack thereof, that's a really great place to start, is just knowing, is my chest moving and are my ribs moving? The answer to the first one should be only a little bit. The answer to the second one is kind of a lot.
Okay, that's actually really helpful. I'm definitely going to try that later because I know I need to work on my breathing, especially after sitting at the computer so much and being in quarantine so much. But I have another question from the audience. Would the average physical therapist be able to help with pelvic floor? Is that something that we would need to ask for a specialist who specializes in pelvic floor therapy, or are all physical therapists trained in the pelvic floor as like the standard education?
I wish they were. They're not. There is a class in grad school that everyone generally takes. I think mine was 2 days. I think it was 2 days out of my 6-year education that covered pelvic floor. So okay. It's not terribly, you know, in depth. So no, you do have to work with a specialist who has taken the advanced classes that you take once you've graduated school. Our practice is primarily trained through the Herman and Wallace Institute. But there's also the APTA. They're lovely as well. There's Pelvic Guru. Like there are many, many, many pelvic health resources for physical therapists, but they have to have taken the classes.
They do. Okay. So is there a way, like a website or a place that you can go to find a pelvic floor therapist in your area?
Yeah, you can go through the APTA for sure has just a list of anyone who does that work and is affiliated with the APTA. I believe Herman and Wallace has one as well. I can't speak to that one. I don't know if I can trust my memory on that one, but I'm pretty sure there is as well, but at least the APTA. And then also Google.
Yes, I'm all about Google. Definitely. So we don't have any more questions from the live audience, and so we can get ready to wrap up. But I wanted to thank you, but I also, before we go, I just wanted to see if you had anything else, advice, tips, tricks, ways to advocate, ways to educate, things that we can do as patients and things that we can do to help medical providers be more inclusive and focus on pelvic floor and take our pelvic floor problems seriously. Would you like to leave us with any words of wisdom from being in this profession and pioneering in many ways?
Yeah, that's a big question.
Sorry.
A lot of IBD patients, I mean, you get dealt a rough hand. You not only have to deal with the symptoms, but you are an island a lot of the time. There's a lot of self-advocacy. And so what I want to pass on to a lot of patients, clients dealing with these symptoms, one, I'm very sorry that you have to be such a strong self-advocate. That is not fair. That is my job, not your job. And so a lot of when it comes to advocacy and making sure that needs are met, properly met, you know, that the whole body is being viewed and not just this one little body part, not just one little portion of the intestine, but who are you kind of functioning? How are you functioning as a person? Is if you do have the energy, if you fully have the spoons, see if you can advocate for yourself when you're not in the clinic with various providers, because often in the moment, that's a lot of pressure on people. But sending articles, connecting providers, one who may be really, really competent in this kind of cultural realm and one who maybe is struggling. Great, get them together and let your other providers advocate for you. That is a very appropriate thing to do. But also, if you have a strong need and you feel like you can't do it verbally, send an email, send a letter, do the advocacy that way so you can actually, one, know that you were heard, and two, know that if you are not seeing the results, it is not on you. Your provider should be listening. Your provider should be taking that information in. Even if they don't fully understand, you know, they can make a couple phone calls, talk to a PT, check out this article, learn a little bit. So yeah, I read this article today while I was preparing for this talk that said that folks who are dealing with IBD, often it's similar to the trans experience of coming out. There's so much education and there's so much identifying. Like, I am a patient who has IBD. I am a patient who is transgender. There's so much that goes into that. And there's so much emotional labor that there often is a lot of overlap. And so as far as wisdom goes, I don't know if I have too much, but know that there are providers who are actively engaging in trying to make this a better world for folks who are dealing with these chronic illnesses and trying to advocate for you.
And we so appreciate you doing that for us, for our community, and for the future of IBD and the LGBTQIA plus community, and just being inclusive of all people. We so appreciate that. And we really appreciate all of the tips and tricks and knowledge you have given us. I know I sure appreciate it. And I'm definitely I've started pelvic floor therapy, but it kind of was a stumble upon as opposed to something I was educated about by a medical provider. So I think we're all going to hopefully feel a bit more empowered now. And so I really appreciate that. And do you have any last words or anything you want to plug? Did you want us to follow you on social media or anything like that?
Well, now that you bring it up, Our Instagram is Body Connect DC. We do post semi-regular content on the intersection on pelvic floor, postpartum health, gender inclusive health, bowel health. I did a series a few months ago, time means nothing, on some general like bowel tips and tricks. So we do have some great resources there. But no, I just thank you for including us in this conversation. Thank you for having this conversation. Thank you for thinking to have this conversation. It's a rare experience, and it's a good one.
Yes, absolutely. Well, thank you so much for being here. We will have this recorded and posted pretty soon. So for folks who missed, or if you want to rewatch it and listen again or listen later, you can follow Galley Health on Facebook and Instagram, and hopefully we'll see you soon. But yeah, just take care and stay well and stay safe and healthy, everybody. Bye.
Bye. Thank you.
Thank you.